Hello, everyone, and welcome to GBMC's Greater Living Live. I'm Mary Beth Marsden. First, I just want to say I hope that you are all doing well. We are living in an incredibly difficult, ever-changing, just almost unbelievable time, and I hope that everyone is coping. I know that one of the goals of this program monthly is to try and bring you information to help you with your health, to help you with how you live, especially during COVID-19. Today's topic is something that may be a little difficult for some people, but it is incredibly important. And so we want to focus on it. We want to spend the next hour focusing on it in a way that is thoughtful and helpful to hopefully everyone who is watching, who is listening, who may have questions, and feel free to ask questions on Facebook Live if you're joining us live. Joining us right now to start off our conversation is Dr. Anthony Riley, who is the Chief Medical Officer at Gilchrist. And Dr. Riley, thank you so much for being with us.
Thank you, Mary Beth. I'm glad to be here.
I think anyone who's lived in Baltimore for any length of time knows the title of Gilchrist. We often have heard it called Gilchrist Hospice care. But you've changed the name, you've shortened the name a little bit just to simply Gilchrist because you offer so many things. So I want to just start with an overview of what exactly Gilchrist is now and what you provide.
Yes, thank you for that question. Gilchrist is a serious illness organization, and all of our services are designed for caring for patients who have serious illness, regardless of their stage. And so we provide under this umbrella hospice services, for which Gilchrist is best known for, but also frail geriatric services and then integrative and palliative medicine services as well. So we provide services across multiple continuum of care.
And I'm going to continue along this line of sort of the overview just so we get people on the same page. When someone is seriously ill, possibly terminally ill, or is having a long-term illness, what are some of the different terms? Because it gets confusing. It's such a heightened emotional time for the family that we often don't understand what the terms palliative care mean or home hospice, and what are some of the differences?
Yeah, so again, that's a terrific question. It's one I get almost all the time. And I like to use the term serious illness because it conveys, obviously, the seriousness of the medical situation. Other terms that are used are complex illness or advanced illness. Generally, it conveys a medically serious set of problems that the person has. They can be acute. And often we're seeing patients in the hospital setting, or they can be chronic over multiple years.
And at which case hospice still plays a role, or Gilchrist rather, still plays a role in helping families and helping patients kind of manage their lives through that period, right?
Yes, and the idea is that hospice is towards the end of this continuum of care. But patients with serious illness often have the same needs, the same psychological needs, the same caregiving needs, the same need for advice and counsel and anticipatory guidance, even though they may not be eligible for hospice. In fact, the majority of our patients in Gilchrist through our frail geriatrics are not eligible for hospice, but they have the same set of needs that hospice can provide. And so we're able to bring this array of services to patients upstream before hospice. And that makes a huge impact on their planning for their subsequent medical care. And this is why we're so interested in getting the word out about advanced care planning.
Okay, so advanced care planning, I think, and you and I spoke just before the program began about how COVID-19 has left us, so many of us, feeling out of control. We can't control what's happening. No one can control this virus. We can take certain preventative measures, but really you just never know. You don't know how it's going to go. We don't know how the numbers are going to go this fall. So it leaves you with a sense of anxiety because you can't control. But What we want to focus on today, at least partly, is some of the things that we can control when it comes to our lives and comes to the decisions that are being made. So let's start with the one term that we do hear, but I don't know that many of us have really fully delved into, which is, and you just touched on it, advanced care planning.
Yeah, so certainly in the COVID era, advanced care planning has become very, very important to anyone of any health status. So individuals of all ages should be considering this because you don't know when a health crisis is going to occur. Advanced care planning helps anticipate the medical catastrophes, which are terrible, like COVID or automobile accidents. And yet advanced care planning is best used for individuals who have worsening chronic medical conditions. Dr. Modermass will help talk about those early conversations. And advanced care planning is actually very simple. There are 3 simple steps. The first is to choose a healthcare agent. The second is to realize that medical decision making is a skill that has to be practiced and worked on over time. And the third is then to talk to your healthcare agent about what ifs. These are the contingencies. What if something happens? What will happen? What do you want? How will we make decisions? Dr. Modermass will talk about the choosing a healthcare agent and the what ifs, and I'd like to focus primarily on the working on those medical decision-making skills.
Okay, let's do that then.
Because there are differences.
Go ahead and talk about the medical decision-making skills. And when do we need to have those skills, and who needs to have them?
Well, I think people are put off by advanced care planning because medical decision-making actually is pretty complicated. And that's why we turn to our doctors to help us talk through. For those individuals that are healthy, the basic decisions are pretty simple. And if I'm healthy, antibiotics I definitely want. I want to go to the hospital. These are simple decisions because I can benefit from the medical interventions that are available and offered routinely when I present myself to the hospital or to the physician. However, it's different when I have worsening chronic medical conditions because medical interventions have risks on the one hand and burdens and also benefits. But as I get frailer and my medical conditions are worsening, those medical benefits get smaller and the risks get bigger, and my medical decision at that point about that intervention might be different. And at GBMC and Gilchrist, we talk about patient-centered medical decision-making, and that's what it means, that we get to know you and your values and what you're feeling about what would be best for you under certain medical conditions.
Which is why it strikes me as we're having this conversation how important it is to establish relationships early on in a condition or an illness.
Yes, that's right. And I view the medical decision-making as a long-term process. When you visit your physician, say you have early Alzheimer's disease or have heart failure or obstructive lung disease, there's an awful lot of information to learn about. And your doctor generally knows about what kinds of complications exist down the road for you on your medical journey. And those discussions about those potential complications and the treatments for them should be discussed in the quiet of an office with reflection and plenty of opportunity to discuss and consider, because these decisions are not easy decisions, and they're also ones that should not be made in the midst of a medical crisis. That's probably the worst time to be making these kind of decisions.
Are they also decisions that should not be made, if possible, alone?
Yes, it's very hard to process the kinds of information that a physician might present, because generally the information is presented in the form that's in statistics, percentages. You really need to have someone to help you understand what the doctor is saying. Many times a medical translator is an important role that we play in Gilchrist, and certainly the primary care physician plays that role as well. What exactly did I just learn from my visit with the specialist or the oncologist or the cardiologist? And translating into what it means for you, and then how it impacts your weighing those benefits and burdens that every medical intervention might have, and whether it's the right thing for you.
What are the special challenges now during COVID-19? Are some of these conversations, Dr. Riley, happening via telehealth?
That is an excellent question, and it's one we've grappled with and have gone back and forth on. The fact that we wear masks and shields makes communication difficult even if you are in front of the patient, and it's very hard to have these kind of conversations when it's done over the phone or through a video connection. These are challenges. Our team has risen to that and has found that there are some benefits in doing that. The main benefit of the telehealth visit is that families and the physicians and the others are much more accessible. They don't all have to geographically be in the same place. So we're finding that there's a great willingness for other family members to join us in these conversations.
Do you find that you gain some insights into the patient themselves just by seeing them in their home environment?
As a home-based physician and geriatrician, I learn an awful lot from being in the home. You learn about their circumstances, you learn about who else is in the home. It helps me understand who the other stakeholders are in the decision-making. And yes, it does help me really understand the context in which the patient's making decisions. Many of the advice and interventions that physicians may recommend need to be tailored to that home environment. So that's really an important piece of the information when you're making decisions, particularly when some treatments are very burdensome and a challenge for the individual to actually carry out.
Can you give us an example, and not anyone specific, but just something, a common example maybe, of someone facing the decision whether to continue treatment or not continue treatment? There must be situations, maybe with cancer, that come up where now the treatment is going to lead to a poor quality of life. Can you give us just an example that is sort of broad?
I think the biggest and most commonly cited example is that of continuing chemotherapy when the cancer is advancing and causing the individual to become even more frail and fragile. Under those circumstances, the benefits of the chemotherapy may be quite marginal, and the burdens and the side effects may be quite substantial. And it's at that point that that balance means that you should probably stop the therapy at that point, because the benefits do not outweigh the burdens of the treatment.
Do you feel, and I'm guessing that you do because this is your line of work, but do you feel that all of us could have conversations with our families about, if I'm in a situation like this is what I think now, or finding the person within your family, or even a friend, if you don't have someone in your family, who would be that person who would advocate for you? I think we get slammed with an illness and we're unprepared for who to bring in that circle and who helps us with the decision-making process. How do we become better decision makers, I guess, is my bottom line.
Well, I think you've used a term that I like, is that circle. I think the circle needs to be wider than the patient and the physician, because we need to know other stakeholders, particularly when individuals have to depend on others. In my line of practice as a geriatrician, there's often caregivers involved, family caregivers, hired caregivers. These are individuals that have to carry out what's being recommended, so they need to be part of that decision as well. I think when families get together, it helps, and go through this advanced care planning process together, it helps to avoid the frictions and the conflicts that occur. One of the biggest disheartening events that I see, and I think it's avoidable, is the fighting at the bedside. Mom's in the hospital, or mom is having a serious medical crisis, and the family is at odds with each other about what to do. When that work is done up front, in the outside of a crisis, the family dynamic improves substantially, and they're all focused now at the bedside on how do we get mom better, as opposed to the conflict that can erupt among family members. That's one of the main benefits of advanced care planning in my view. Some of the other ones are, as you alluded, having the confidence that you talk to an individual that can really represent your goals and what you would like to have done.
Everyone is so different in how they view illness or death and dying, or how they understand what is happening or what they want to deal with. How do you, as a physician, and as a person running this wonderful organization called Gilchrist, know how to talk to each individual? Is there one way that you find is really a great fallback for everyone? Is it being open and honest, unemotional? I mean, how have you found that sweet spot?
The sweet spot is what the patient feels. It sounds like a simple answer, and I usually ask. I ask an individual patient, and when I'm getting to know them, how do you like to talk about these things? How much information do you need or want? And who else should I be talking to? So I let them lay the ground rules. And that, if I do that well up front, that avoids many of the kinds of miscommunications or misunderstandings that occur down the road. People do vary, and it's very helpful for me to understand that I may have a patient who says, I want the chemotherapy because it has a small possible benefit. I'm willing to take the risks and to bear the burdens of that, and I want to have that chance. And that individual, I need to know, is making decisions from that perspective. There are many other individuals, though, that weigh it differently and say, the pursuit of medical benefits isn't the only thing that's important in my life. I want to pursue some other things. I think we all, as we've seen others go through various treatments, know that treatments, if you're committed to the treatment, it can be very time consuming, and it requires a major commitment in your life. And if you're not willing to prioritize the medical interventions to that degree, and you favor other priorities, family priorities, you may make a decision because of the high burden of pursuing that medical intervention that may have marginal benefit. So I need to know that up front, because if I have an individual that is wanting to have every chance at a small benefit, even though it may be very burdensome, I need to know that, offer these opportunities, and to manage more medically aggressively than I might with an individual that has a different philosophical perspective. So I have to ask that up front.
That is such great advice, because I think so often we assume that we know how someone's going to react, or we think that they feel the way we feel. And all we have to do is just start asking questions to kind of gauge what they want to know and what they want their life to look like.
Yes, and I think the medical system is geared towards the individual that presents themselves in the emergency department. And when they present themselves, that's a request for help. And the doctors say, I'm here to help you. I'm going to do this. And that starts a chain of medical interventions that perhaps the patient wasn't quite prepared for. And that's why these conversations in advance are so important, because they present themselves to the emergency department because they need help, but they may have in the back of their head some limits to how far they would go. For example, in the COVID world, with my patients who have advanced illness or advanced age, they may not wish to take the route that lands them in the intensive care unit on a ventilator, but they may want other chances short of that.
So now it sounds like we're getting into the term directives. Am I right? There's a difference, right?
Yes, yes. So I think of advanced planning as the process of determining what your wishes are, and advanced directives technically are the documents that are generated as a result of that advanced care planning process. So when you're ready and have thought about it and have discussed it with your circle, you can then commit this to paper, and the documents typically are the appointment of a healthcare agent, and Dr. Modermast will talk about that. And typically it's 5 wishes or another advanced care planning document. And finally is the medical order for life-sustaining treatment. That's the actual order that tells the physician what you want and what you don't want at that moment in time.
It strikes me, and I know GBMC is, they very much promote the team aspect of providing medical care. So are there social workers on staff with you? Because it seems you have to be in this moment in someone's life kind of all things.
Yes, this is a team activity. It's a very important one because I, as the physician, may not be the best communicator for certain aspects of this. So having the chaplain and the social worker, and certainly the nurse is also an important part of this. So that, yes, having the team enriches the conversation. Ultimately, it has to translate down to a document and a physician's order, but it is a team activity. At Greater Baltimore Medical Center in the hospital, we have our integrative palliative medicine team that is helping patients and families do this work. In the hospice, we have social workers, and our nurses are very adept and skilled at doing these conversations. And in the office, Dr. Modermast can comment further, but in the office there are opportunities to talk about this with your physician. Generally, once a year through the Medicare insurance, this is a conversation that is designed to occur, and time has been set up and set aside for this conversation.
One of the, I think, biggest fears about COVID-19 with regards to yourself and also your loved one is that someone may be seriously ill and they'll be isolated. We've seen so many stories of people dying alone. The nurses and the doctors try to help. There's no communication. And you particularly, coming from the Gilchrist end of things, so focused on helping families deal with death and dying and saying goodbye and having a meaningful end of life. This must be just heartbreaking.
This is one of the probably hardest things for us as a team to see this, because it creates enormous suffering in our patient and families, and also distress to those of us that witness this suffering. It's very, very challenging. At the hospital, we try with the tele connections to do this. And I know that the nursing staff there really make an effort to include the families when they can. And certainly our palliative team does that as well. At the nursing facilities where we provide services, again, we're working through the same tools, the same tele-visiting tools that are available because of the very tight restrictions on visitation there. And then at our Gilchrist centers, we do take patients who have COVID, and we have visiting hours for families for patients who are dying. We put those families in the appropriate personal protection equipment so that they can visit safely, and we allow that to happen in recognition to the very significant and tragic end-of-life situation that their loved one's in.
Finally, just to try and end on an up note, hopefully, is there something at this point, maybe too soon, but is there something at this point that you can look at and say, COVID-19 has changed the way we do this, and maybe that's for the better?
I think there is an upside to, a bright side to all of what's happening. And in our team, we've tried to focus on ignoring the uncertainty. There's so much uncertainty out there in front of us. I do have control over myself today and our team today and our patient care today. And if I can be better at it today than I was yesterday, we're moving in the right direction. That urgency to be better today is I think, a huge lesson in the face of the COVID uncertainty.
Dr. Anthony Riley, thank you so much. Thanks for everything you're doing, and especially during this time. And we really appreciate your insights. And I know we're going to get a lot more specific now with Dr. Modern Mass. Thank you, and have a great day.
Thank you.